have any of you been to the American Academy of Otolaryngology? I'm sure many of you have. The American Rhinologic Society is always the day before the Academy, and it's in a nearby hotel. But you'll probably get, if you're interested in rhinology, you'll get more rhinology in one day. Now it's going to be a day and a half at the ARS than we will the entire week of the American Academy. So this is particularly important for those of you that really want to hear the latest in rhinologic innovations. And now they're now we've started in the last year cadaver dissections that are free and things like that. Also for the residents, outside on the table, we put these little folders that look like this, and they've got some opportunities. I've been asked if there are dissection courses, and we do have an annual dissection course. You see all the way to the left. In January of the year, we certainly have our dissection book that's routine.com, and in our mini fellowship program, the 3 to 4 week mini fellowship program, where they observe and work on multiple cadavers. So there are educational opportunities available to you. And again, it's all listed in the white folders outside. What did I do here? Let's go back again. So, it's, for those of you that like scuba diving, actually that's me and two of my sons, you know early on that when we scuba dive, we have to have landmarks to know where we are underwater. We do have a compass, but we still need to have landmarks so that we know where the boat is and how to navigate underwater. Sinus surgery is not unlike scuba diving. What are those things at the top? I don't know what these things are up here. It's funny being at a podium and sitting and standing and talking and listening to colleagues when they go out there presenting particularly revision cases, and you hear over and over again saying, well, these cases have no landmarks. Well, every case has landmarks, and we learned that early on as otolaryngologists, particularly our otology colleagues know that very well, that landmarks always exist for surgery. It's just that there's different types of landmarks. And this goes, as you heard yesterday, for the maxillary sinus, the sphenoid sinus, and even for the frontal sinus. And I hope to share some of these pearls with you after many years of experience, not just as a professor teaching students, but also as a professor learning from students to see what works and doesn't work for them when they're learning. The reason we want to know landmarks and the reason we have to know landmarks is because you never know when the worst thing can happen during surgery, and it can happen in the worst possible moment. As you're doing surgery, things can really go bad really quickly, and you certainly don't want that to happen to you in surgery. So it's very important to understand. So yesterday you learned a little bit about some of these landmarks. You learned, like the green line right here represents the orbital floor, and you know that if you follow that orbital floor posteriorly, it always leads you right over here to where the red line is, right there where they intersect, and that's the area of the natural ostium of the sphenoid. And you also know that this red line represents a very important coronal plane, because a lot of things happen at that coronal plane. And by finding one structure in that coronal plane, you can find another structure. So if you're in the lower part of this coronal plane, you know that if you go laterally, you're going to go into the pterygomaxillary space. First of all, the sphenopalatine foramen, then the maxillary space, pterygomaxillary space right behind the maxillary. If you go superiorly up here in this area, this line is going to cross through the orbital apex and the start of the optic nerve, the canalicular portion of the optic nerve. Regardless of whether there's an anode cell or not, this plane is very, very important right up here. And of course, the line itself represents the plane of the anterior wall of the sphenoid sinus. When it comes to the frontal sinus, of course, it's this yellow line here. And this yellow line represents the coronal plane, as you saw yesterday, of just the anterior to the anterior wall of the ethmoid bulla, if it's present. If it's not present, then it's the area just at the level of the natural ostium of the maxillary sinus, which is only a few millimeters behind this oval yellow line and parallel to it, which represents the nasolacrimal apparatus. So when you're heading towards the frontal, you're really heading in the plane that's going to be at the coronal plane of the natural ostium of the maxillary, heading in this direction, just parallel to the nasolacrimal. Note that the nasolacrimal, this mucosa here, that's anterior to the attachment of the middle turbinate, is almost never involved with polyps. So in fact, we can almost identify where the lacrimal stops just at the insertion of the middle turbinate and when the normal mucosa starts, because it's just where the polyp starts. So it's a very important landmark. And of course, when we're doing these things, you know, you heard yesterday that the three things we use, not by itself, but in combination, are the colomellar measurements. We use that antrostomy ridge that we talked about to know where we are relative to the ethmoid cavity. And of course, the medial orbital floor, this white line that allows us to know that if we're above that line posteriorly, you're within 5 to 7 centimeters, you're going to be in the posterior ethmoid cavity. If you're below that line immediately, you're going to see that most of that sphenoid sinus is going to be below that line. So you have to know these relationships. And it's not that important when you see normal cadavers like we saw yesterday, but this will become more apparent to you when you start engaging in cavities that are bloody, that have polyps, and that have revision cases. These are the types of landmarks you use for revision cases. And of course, we know that we want to follow that floor of the orbit down here as the correct trajectory into the sphenoid, and in some cases we want to go through the basal lamella, this portion of the basal lamella of the middle turbinate, in order to enter the inferior posterior ethmoids. And why? Because the first thing we want to do is we have to identify the orbital wall, the medial orbital wall somewhere. Because once you find that sagittal plane of the medial orbital wall, now you've got an identification where to go posteriorly and anterior and try to avoid damage to that structure. And these are two cases with polyps. These are the type of polyps you typically see in the northern part of our country, and more percentage. It's not to say they don't see these type of polyps, and you guys are very well familiar with this. Okay? This is AFS, right? This is what we see in South Florida, in the southwestern United States. This is what they see in the northern part of the country. Totally different. Polyps, these are polyps, may or may not be too inflamed, too inflammatory, too adherent, too fibrotic. These are very adherent, very fibrotic, very inflammatory, high residual chance of recurrence. These polyps, you can do any kind of technique you want. You can see here, you still have all the septations, lamellas as they refer to them, of the ethmoids if you wanted to identify them. You can still preserve a lot of mucous membranes because you see they're aerated. These, I dare you show me one lamella in this one. You can't use lamellas, you can't use turbinates, you can't use anything. The only thing that's intact there is the orbital floor, orbital wall. So you have to have a technique that uses the existing anatomical structures to navigate you, to guide you in the right direction towards the sphenoid, and right now we're going to talk about the front. Come on. So how about the front? In the frontal sinus, of course, we want to find the passageway of the frontal that's between two columns of cells. The one column is that of the uncinate process leading to the agonazzi, and perhaps some more cells above the agonazzi that we refer to as frontal infundibular cells. Okay? So that's one column. The other column that runs parallel to it is the ethmoid bulla and a variety of suprabullar cells that occur above it. some which are fairly pneumatized, some which actually extend over the orbit and can be fooled. A person can be fooled thinking it's the frontal sinus, where in fact it's just extensions of these cells. So it's important to find this space in between, right here, this infundibulum, this opening to look up into the frontal, as we do in the different draft procedures. So in a primary case, it's very simple. You know that you want to stay at the coronal plane of the face of the bulla, or lower down the natural ostium of the maxillary that's around the tail of the uncinate process. You all saw that yesterday. And we want to head up against the vertical lamella of the middle turbinate. In this case, we've reduced the head of the middle turbinate just so that you can see the extent of the uncinate process. And I can tell you more and more in the United States, we see more and more people who used to not do anything to the middle turbinate, doing more to the middle turbinate, fully recognizing that the middle turbinate is really an extension of the ethmoid complex. And particularly when it is pathologically affected, more and more people are at least reducing the anterior head. Why? So that you don't fracture the lamella of the middle turbinate, and two, so you can see the structures of the middle meatus and do a safe surgery. The whole thing here is to get the patient better, but to do it in a safe manner. Let's see if we can get this going. Okay. So there are different variations of the uncinate, and you can see here where we have the uncinate. Here's the uncinate process, ends prematurely right at the face of the suprabullar area. In other words, this is the bulla. There are cells that sit above the bulla, and the uncinate attaches here. Contrast it to this one, where the uncinate goes all the way up and attaches to the vertical lamella of the middle turbinate. It probably doesn't make a difference where the uncinate ends medially here, because it's so variable, and because really the frontal recess, which is where the asterix is, the entry into the frontal recess, is going to be in the same coronal plane. It's still going to be roughly at the coronal plane of the face of the bulla or the ostium of the maxillary, as I noticed. The only difference is the secretions from the frontal in this scenario here will be entering the upper parts of this ethmoidal infundibulum behind the uncinate. Whereas here, where the uncinate ends prematurely, and you can see the asterisks here, the secretions of the frontal will drain directly into the middle meatus. And that's about the big difference. So if you know where if you see the maxillary atrocity, you know where the natural ostium is here, just behind the nasolacrimal, and just behind the insertion where you see that little letter A here of the middle turbinate. You want to go in this direction towards the frontal infundibulum, and that's between the anterior ethmoid artery, right, making up the back wall of this last suprabullar air cell, and right behind the insertion of the middle turbinate. But you're going to do this medially up against the vertical lamella of the middle turbinate. Here's an endoscopic view of an Agranazzi cell. This is the insertion of the middle turbinate, Agranazzi cell. Just above it is a type 1 frontal cell, and we'll get into that in a second. So this is one column of cells, starting with the uncinate, Agranazzi, type 1 frontal cell. And remember that the lateral part of the uncinate inserts into the floor of the Agranazzi. So you merely have to follow the uncinate process up laterally on the orbital side, and you'll insert into the floor of this cell. And of course, if you keep going up through that cell, straight north, basically, you will be entering the frontal infundibulum. The other set of cells, the bulla, the suprabullar cells, are a tad bit more posteriorly. Only a little bit of the anterior roof of this last suprabullar cell really extends into the floor of the frontal infundibulum. If you go too far posteriorly, you will be entering in the area of the anterior ethmoid artery, and of course, that will go intracranially. So if you're going to err about going into the frontal, err on going too far anteriorly, not too far posterior. So the other thing, this is the left side of the nose. The way you put the probe to find your frontal makes a big difference. This is the wrong way on the left side to put your probe in. You should not be resting your probe on the orbital wall and inclining it this way. If you do it this way, the chances are of going in through the lateral lamella of the curviform plate is very high. Whereas if you rest your probe this way and you angle it supraorbitally, your chances are you will be going in the right direction of the frontal infundibulum, going over the orbit. So it's a matter of how you use your probes as well. So in revision cases, we really have to go by other landmarks. We certainly use the convexity of the nasolacrimal. We want to stay at the coronal plane of the natural ostium of the maxillary, just behind the lacrimal, and stay parallel to it, going up just behind the insertion of the middle turbinate. But we want to hug the middle turbinate with our probe and point the probe laterally, not medially. Again, you want to stay between the red shaded air cells and the green shaded air cells. The red shaded air cells are the uncinate, where it inserts into the floor of the argonausi, and then of course any other cells that may be above that. And you want to go over, if you want to really see the front, you've got to remove the dome, this upper dome of this cell, and go straight up. And to open it, the AP, you got to remove the dome of these upper supraorbital cells in the green shaded area. So if you look at a case like this, where it's got polyps, the arrows point to the nasolacrimal. This is the wrong, as I showed, area. I've already done the ethmoidectomy, taken the polyps out. This is the right direction on the left side that you want to go, hugging the middle turbinate vertical lamella. We use probes. Other people have used balloons to feel the frontal. It's a two-finger technique to feel the back wall, to dilate it, and then we use an angled microdebrider to collect the debris. We do not use the microdebriders to explore cavities. We do not use microdebriders to push. It's only to collect tissue. If you do use it to push, you can get into trouble with orbital injury. So these are the different cells that can occur at the level of the argonausi. Type 1 cell, of course, these are Kuhn's classification. And this is above the argonausi. 2 cells is above, type 2 if it's more than one above, and then the type 3 if it goes over the orbit, type 4 if it's an independent cell. And don't forget the inner sinus cell of the frontal. Some people can confuse this cell with the actual frontal, particularly when they're doing balloons and they transilluminate. You're taught when you use balloons to transilluminate over the orbit, not in the midline. If you transilluminate in the midline, you can be into one of these inner sinus cells. That's different than those that you transilluminate over the orbit. So the different types, of course, is the type 1 frontal sinusotomy, where you essentially do an ethmoidectomy but preserve the dome of this last cell. It's the last suprabular cell or the last argonausi or type 1 or type 2 frontal cell, whichever is the last cell in that column. And you really are only opening up, you're only doing an ethmoidectomy and preserving the space between the medial wall of these upper cells and the vertical lamella of the middle turbinate, but you're not going into this upside down snow cone area here. That's the frontal infundibulum. So you never really look or transilluminate up into the frontal. So that's a type 1. And the kind of things that, the type of procedures that you would do, this happens to be an in-office balloon procedure where we go behind the uncinate, and we're just going to address this opacified frontal and a person who likes to dive, didn't want to go to the OR. We're just going to do some anesthesia. That's a little different talk for another day. And then we just balloon that area and suction out the mucus. So we stay behind the upper attachment of the uncinate process. We probe it, we balloon it, we dilate it, and then we look to make sure it is patent. And then the patient, of course, has this kind of results. We're just merely ballooning it in the office, and this spares them a visit to the OR. In a type 2A frontal sinusotomy, now you've removed all the ethmoidal cells all the way up to the dome, just so we can see where the asterisk is here, the frontal infundibulum. Many other names, including frontal opening, frontal ostium in the old days. The point is you're going to start looking up, and you're going to start looking as you remove the dome of this type 1 frontal cell. Sometimes it's just an argonausi cell, but if you remove this dome, you'll progressively look up and you see the frontal sinus. And don't forget that if there's an opening medial to that, that's probably an opening that goes to the intersinus cell. Don't confuse that with the frontal. Typically the frontal opening, the frontal recess opening, is the most medial and anterior opening. However, if there's an opening medial to that, and you found the frontal a little more lateral, and you can see this on CT by the way, then it's probably an intersinus cell. and you can have inner sinus cells draining on either side of the nose. In a type 2B now, it's basically a type 2A where we remove all the ethmoidal cells to look at the frontal infundibulum as we saw previously. The difference is we're removing this portion of the middle turbinate head and vertical lamella all the way up to the skull base. If you recall, the medial wall of the frontal infundibulum, so this wall over here, a little further anteriorly, so this wall right here is the medial wall of the frontal infundibulum. In order to enlarge the medial wall of the frontal infundibulum, you have to remove the base of this middle turbinate, right over here. So you have to remove this portion, and you can see it endoscopically below, where we've removed that portion of the middle turbinate to see the medial, where it inserts into the medial wall of that type 2A frontal sinusotomy. The only thing, the main landmarks here, in order to go from left to right, right to left, whatever direction you want, is to learn to identify where are the anterior fibrils of the cribriform plate that are marked by the little arrows here. And there's an exercise we do in the lab with the residents where we intentionally have them find that little edge. It's like a bony edge, and it's like a trough. It's a V trough. And you actually elevate, and you'll see the fibrils come in. Once you identify that, then you can remove everything anterior to that, and you can go from left to right through the junction of the perpendicular plate of the septum and the inner sinus septum up here, and extend this frontal sinusotomy all the way to the other side and actually go from left to right. If you just remove the bone over here, this triangular bone, but don't go to the other side, that may give you about 3 or 4 millimeters more medially, and that's what we call a draft 2B, okay? So we use a bunch of instruments, but probably the main instruments we use to do these extended frontals are the C-spine curettes. They come in different sizes, different angles. The orthopedic and neurosurgeons use it for the C-spine. They're very hard curettes. We get started with those, and then we do the finesse work with the angled drills that are available that irrigate and do the work. So in a draft 2B, we basically go through and start with removal of that portion of the middle turbinate. We remove this triangle right here in this area and extend it to a draft 2B. In a draft 3, we basically, it's a bilateral draft 2B. Okay? All we do is remove the inner sinus septum and where it continues as a perpendicular plate. So we do a bilateral 2B to communicate orbit to orbit. And these are the structures we want to remove. The main thing is, if you see the blue line here, is as you do a draft 2B, you have to be cognizant where the anterior most portions of the cribriform plate is. Most of the olfactory fibers are going to posterior to that line. So if you stay anterior to that line, you're safe as far as olfaction. We do a superior anterior septectomy of variable degrees so that we can work from either side simultaneously. Drill on one side, telescope on the other side, be able to use both sides to work. This is some of many studies showing the presence of olfactory fibers, and you see the concentration of olfactory fibers outside the cribriform is mainly high up in the vertical lamella of the superior middle turbinate, right here, posterior to that line where is the back wall of the frontal. And on the septal side, again, it's high up in the first centimeter or so. And I have a partner that does stem cell research right now on olfaction, and we're doing a lot of re-injection for anosmia with stem cell at our Stem Cell Institute. And so we've learned a lot more about this. And olfactory cells are probably, the fibers of olfactory are probably the most highly regenerative and stimulable nerve fibers in the body. Just the mere presence of trauma can stimulate reproduction. This is the final Lothrop size, and this is something that you want to manage patient. And the interesting thing is we do these a lot for polyp patients, for people with a lot of osteogenesis. And the whole purpose is that it's for topical therapy. The real treatment is the topical therapy that happens afterwards. And in order to get the topical therapy into the frontal and henceforth the rest of the sinuses, we create these cavities because there are many companies that now make it for us, but we have many different irrigations and topicals with virtually any antibiotic and all those very strong steroids. And that's how we deliver it into these cavities to control it. So when you convert from a draft 2B to a draft 3, all you're doing is taking this inner sinus septum and part of the perpendicular plate. The asterisk is where the curviform plate is. Once you know where that is, everything anterior to that is fair game. You just go for it and just remove it. And you'll practice that, hopefully, for those of you who want to do it in the lab. You drill it down, you see you start entering the right frontal, and you continue taking it off, and you actually can do a Lothrop from left to right without even touching the right side. You don't necessarily have to do an ethmoidectomy on the right to do it, although it's possible as well. And again, this is just a completed Lothrop looking from the right side, from the left side still, and you can see the right sinus, left sinus. And then if you go to the right side and look over the left side, one of the advantages of the Lothrop is that you can address pathology over the orbit. So you can go from right to left to get over the orbit to get to pathology up there, like inverted papillomas and certain tumors. This was the last study we did years ago, and it hasn't really changed. We know that about 94% of the patients remain patent. Of those, 33 are less than the original size, 50% less than the original size of the intraoperative opening, but still asymptomatic, and they do well. There is about a 10% incidence of reclosure completely. Most of those are asymptomatic. Some have to go back to either a redo Lothrop, or very, very rarely do we ever do an obliteration procedure. Special considerations when we do these procedures for extended. There are situations like this where we have a patient with recurring cellulitis, has a little defect in the bone, has an opacified, otherwise hypoplastic frontal, and there is probably an indication, as in this case, to do what we call a transeptal approach, where we go anterior to the normal recess and normal infundibulum. And what we do is we go, if you notice, you don't see middle turbinate on this coronal view. And what we're doing is we're going transeptally or a little laterally, what we call supraterminally, to enter one of the two frontals through this area, find the back wall of the frontal, and once we find the back wall of the frontal, we now just drill it and connect to both sides. So the arrow basically tells you the direction we're going. Notice that we're anterior to the anterior attachment of the middle turbinate. So that's a transeptal approach. And in some cases like this, there is an argument for obliteration, auto-obliteration, where we go in there, drill out not just the opening, but drill out all the mucosa endoscopically with the hope that it will contract, turn into scar and bone, and auto-obliterate like in the old days, except you don't stuff it with fat. And that's basically what we did in this case. The other thing on exam, notice this is the right side of the nose of this patient, this is the left side. When you see this type of pathology high up on the anterior ethmoids around the frontal, this is a clue that it's that the pathology is coming from the frontal sinus. Okay, and of course this is the type of I'm just going to quickly just go through here. We have a couple minutes left, but basically you can see the CT scan. There's a lot of bone to be removed, and basically what we do is we drill that area out. We enter the cavity, and at the end we suction all that pus out of there. And we continue drilling, and we did this in the midline through a transeptal approach to really recreate the cavity and to get all the mucous membranes out all the way around, and we drill it all out. We palpate the nasion and the canthal area because those are our limits. It's okay to see dermis. In fact, we do it intentionally sometimes. We'll drill until we see the dermis of the nasion or the canthus, and then, of course, postoperatively we want to have cavities that contract down and are manageable. We sometimes use rolled silastic. If we do a lot of drilling, we'll leave these in for a couple months. Sometimes we'll change them out. This doesn't really prevent the restenosis or change the restenosis or closure rate, but it does make it easier to manage the cavities with irrigations, and it doesn't hurt when you clean them up there because it's protected. It's lining the cavity. So sometimes we'll use reinforced silastic. Let's go on with this. There are indications like this where there's a patient, a typical patient who's had either a blowout or fracture or some sort of medialization procedure where they continue having frontal procedures, and in that case you do a contralateral frontal and then you cross the midline through a Lothrop from right to left, sort of like I showed you previously. So this is one common indication where you might want to do a Lothrop to be able to address that frontal sinus. Other times there may be meningoceles such as this. Let me go forward a little bit. And you remove the meningocoel that happened to be in the, from the front. This one happened to have one in the sphenoid too. We find a defect, we do a Lothrop so we can work from both sides, control the cavity, and then we put our defect. A topic for another discussion. Other mucoceles, huge mucoceles, sometimes lend themselves for follow-up to do the Lothrop so you can follow them. And of course, pericranial abscess. When I was a resident, these puffy tumors, we used to have to do obliteration. Nowadays, we just, when they do pop up, we do a Lothrop, widely open and irrigate it, and make sure that these patients immediately get better with their problem. And of course, you got cavities that you can follow. And of course, the alternate use of the Lothrop that you'll hear probably in the next speaker is going to be the use in skull-base resection. It's a vital component of an anterior skull-base resection to be able to get the anterior margins of resection along with an extended sphenoid back here and then orbit to orbit resecting the anterior skull-base. Thank you.
Good morning, everybody, and I would like to thank the organizing committee to let me present in this very nice sinus and anterior skull-based course. For all of you who don't know me, there's people from residents from Dama. I'm Talal Tijani, and I'm a rhinologist here in King Abdulaziz Medical City in Jeddah. So I'll be talking about anterior skull-based dissection. One of the nice things I was talking with Professor Kazian yesterday while we were coming back from dinner, and there's two schools in the States now. The school who were doing anterior skull-based, but they're head and neck surgeons, and the school who were doing anterior skull-based who are rhinologists. And there's a difference in the way how they take care of the sinuses. The head and neck surgeons, they just want to remove everything, and they don't really care that much about the physiology, about the sinuses, about the nose. But us as rhinologists, we want to take care of the nose and physiology as much as possible, because that's probably our other, what we do in the clinic. We take care of the sinuses, and as how Professor Kazian said, the medical treatment after surgery, it's not only skull-based, it's also sinus diseases, sinus physiology, and function. So today I want to show you how to be a good rhinologist and a good anterior skull-based surgeon. So my topic is going to be about three things: what, why, and how. So what is the anterior skull-base? So the skull-base actually, it's this part. It's a floor of the cranial cavity, and it separates the brain from the other facial structures. So if you make a line here, the brain is here, and everything else is over here. And Professor Ford is here, Sir Ahmed. And where's our neurosurgeon? The 50%, our partner.
Anterior too far from the student.
So our anterior skull-base, okay. So if you can see this line here, okay, this is anterior planning process. This is the lesser rim of sphenoid. So anything anterior to this, it's the anterior skull-base, and this is what we'll be talking about. And they also divide it into central and lateral. Okay, lateral mostly goes into the intertemporal fossa and tibial and fossa. So why is it important? Well, we have all these structures in our anterior skull-base: olfactory nerve, cranial nerves, and internal carotid artery, brainstem, frontal lobe, and also the CSF, where you could have CSF leaks and sequelae from that as meningitis. So when I first started sinus surgery, and when we were doing sinus surgery, just as a rhinologist, they always told us stay in the box. Okay, and this is, I think that our talk today in the basic course is mostly going to be about FES. Tomorrow and after it's going to be about skull-based surgery. So today we're all going to concentrate how to stay in the box. Tomorrow is how we will go out of the box. Okay. So about anterior skull-based dissection, I think it's a very important to master this technique, and I think it's one of our workhorse areas in, as sinus surgeons. And why is that? Because to do a good FES surgery, and we need to really master this anterior skull-based dissection. In order to remove completely the disease, you don't want to leave any cells on the skull base. And the other thing is avoid complications. Once you know where your skull base is and where all the main structures are, you don't go into the brain, you don't injure any major vessels. About skull base, we'll talk about these tomorrow, but I just want to give you a quick view about the business. We're not going to be here tomorrow. This is the diseases we can treat, and this is the skull base. And these are the ways, or endoscopic approaches, how we can enter the skull base. So the dissection technique, what we usually use is the Maser-Klinger technique. Maser-Klinger, he's what we call the godfather for sinus surgery, and he's from Austria, and he invented this technique in the 60s and 70s. So when we do sinus surgery, we go through these lamella, and if you can see here, we go through the uncinate, bulla, middle turbinate, superior turbinate. Then when we get to the sphenoid recess, we will clean the skull base, or the anterior skull base. So what I want you to master in the cadaver dissection is this technique, going from posterior to anterior and medial to lateral. And why is that? This is the safest way to clean the skull base. And this is actually the way we don't have navigation system. It's going to help us also to get to the frontal recess and frontal sinus, and I'll show you how we do that. But why do we do posterior to anterior? Any of the residents know? So we're on skull base, and we always go posterior to anterior. It's not anterior to posterior.
Just the slope.
Yes, because of the slope. So you want to go. And why do we go medial to lateral?
Away towards the orbital.
Yeah, you want to go away from the LCP, as Professor Kaziani said, and you want to, which is the thinnest part in the skull base, and you want to go laterally because the orbit has a more thicker bone. So it's always posterior to anterior and medial to lateral. And if you see Professor Stamberger, he always uses a curette and cleans that area. So these are the steps. First of all, after we go here, okay, we have to identify the sphenoid sinus, sphenoid recess. Then we have to see if there are any monoid cells. Then you always have to see your skull base, because most of the time it goes upwards, but there are times that it can go horizontal and it can go downwards, or it have a slope. And sometimes they can be defects, okay? Then you want to identify your posterior and anterior arteries. You have to see your curious classification and frontal cells. So about the sphenoid sinus, I'm not going to talk a lot about it. I think it was covered yesterday. But you have to know your sphenoid sinus, okay? Because you have to have a starting point. After you know your type of sphenoid cell, you have to see in the CT scan, is there an monoid cell or there isn't? Because of two points. One thing is, if you are not in the monoid cell, okay, you don't really know where your posterior part of the skull base is. And the other thing, if you are in your monoid cell, okay, and you think, and you don't know it's an monoid cell, and you think your sphenoid is still posterior to it, you might enter the optic nerve or sella or carotid artery, as you can see here. Okay, then you want to, after you see your after you identify your monoid cells and sphenoid sinus, you want to see your sphenoid frontal recess, which is this part here, okay, and your CT scan. It's a space between the superior turbinate face of sphenoid and roof of nose. It's a posterior border is the anterior space of the sphenoid, okay, and natural sphenoid ostium is it's a natural sphenoid ostium drainage pathway. There is no clear-cut anterior or inferior border. So after that, After that, you want to identify your posterior ethmoid artery. Now, usually the posterior ethmoid artery is not like the anterior ethmoid artery. It's either absent, or it's most of the time it's embedded in the bone. 30% of the time you can see it, and less than that, it has dehiscence. Now, this case I did a few months ago, and we could identify the posterior ethmoid artery. Usually it's about 5 to 6 millimeters in front of the sphenoidal recess area. Now, it's really important to see if there's a dehiscence or there's a mesentery in the posterior and anterior ethmoid artery, because when you clean that area, and if there's a mesentery, you might make a tear, or you might cut through it and make an orbital hematoma. And this is our sphenoid ostium here. The other thing is you have to know your Kerouac's classification. So after you see your posterior ethmoid artery, you want to clean the skull base, but you can't actually clean your skull base without knowing this. And all the residents are telling me you have to see this. If you don't, if you can't classify your Kerouac's classification before surgery, you don't get to operate. Because what happens if you get a type D or asymmetrical, okay, with this one, or type 3. I think this was discussed earlier yesterday, but I just want to go through it. Another thing is you always have to see your skull base, because what happens if you don't really recognize this and you're doing skull base? You'll get a CSF leak, you'll get brain herniation, and if you don't recognize that worse post-op, you'll get more complications. So you have to see your CT scan very well. After you finish cleaning your skull base, you get to your frontal recess area. Okay? And the most important area in the frontal recess area is your anterior ethmoid artery. 30% of the time it might be dehiscent, and about 5 to 10% of the time it might be in a mesentery, which means that instead of being here, it's over here. Okay. Now the frontal recess area, as I think they mentioned yesterday, we don't call it the nasal frontal duct anymore. It's an inverted funnel shape, and posteriorly it's bounded by the anterior skull base, and anteriorly by the nasi and the frontal or anterior buttress. Now, the next thing about the anterior ethmoid artery, I'll just talk about it a bit. Where can we find it? It's usually a few millimeters in front of the bulla lamella. So this is the ethmoid lamella, and it connects to the skull base. And right at the attachment or in front of it, over here, you'll find this anterior ethmoid artery. You have to know your frontal recess cells if you want to clean the skull base area, and I'll talk about it more. This is the anterior ethmoid artery. And this is a this is a case I did a few months ago, and this is, you can see your anterior ethmoid artery. Now, the nice thing I want to show you about the anterior ethmoid artery is, as soon as you identify your anterior ethmoid artery, the skull base goes upwards. So if you identify your anterior ethmoid artery, then you know you're safe anywhere in front of that. And that's really important if you have lots of fungal disease, if you don't have a navigation system, you can clean that area. Okay? This is again, I'm dissecting around the ethmoid artery and showing the resident. Any of the residents seen anterior ethmoid artery during surgery? Okay. Now, in all my surgeries who have had sinus disease, I clean the skull base like this. If there's a mesentery and a dehiscence, I have to see the anterior ethmoid artery, because I don't want to be picking any of the cells or the lamella without knowing where my ethmoid artery is. Now, in this case, I cauterized the anterior ethmoid artery, and the reason I cauterized it is there was a lot of bleeding, and just for educational purposes, the resident with me never saw ethmoid artery cauterization. And the other thing, I never pack my noses or sinuses after surgery, so it's really nice to not have any bleeding after surgery. You can see the cauteries here, so actually our video, our camera and our tower is not working, so I have to use my iPhone to take pictures. So, but you can see the cauterization here. Now, the skull base and frontal sinus, and this is what I want. This is another case of frontal sinusitis, okay? And this is how you should be cleaning your skull base in the frontal recess area. You can see I'm picking the bones here, okay? And this cleaning lamella, cleaning the skull base, cleaning the frontal recess area. And then after you clean that, my anterior ethmoid artery is here. This is all posterior frontal wall, and I'm going to put my debrider in here and just fix it anteriorly, and we clean everything here. This is, you can see, fungal debris inside. and this is the debrider. You can see how once you know your anatomy, you're very safe and you can do surgery confidently. This is an agonese. I saw that's a roof of it. The supraorbital cell is removed, and this is the frontal recess area. And you can see how I'm cleaning on skull base here, okay, with my debrider looking anteriorly. I'm not actually afraid of any complications. The other thing is, I'm sure, and I know my lamina papyracea is intact. Okay, and this is how your skull base and frontal recess area should look like after surgery. This is the anterior artery cauterized here. This is supraorbital femoral cell. This is your frontal recess area in agonizate area. And actually what I'm going to show here is the CT scan. Okay, that's a frontal sinus inside. And then this is on the anterior artery, and I'm just going to go show you on the CT scan. You can see the Kennedy nipple here, and you can see the mesentery. Okay, so you always have to see your anterior artery before surgery. 3 minutes? 1 minute? I'll do that. So frontal recess, you always have to see your frontal recess, as Professor Kaziani said. Okay, you always have to see if there's frontal cells, supraorbital cells, frontal cells, supraorbital cells, and frontal intersinus cells. The other thing I want to show you is when you get to your frontal sinus, okay, or frontal recess area, most of the time you'll see 3 holes. Okay, one of them is an agonase and one is the frontal recess, and one of them is the supraorbital ethmoid. How do you know which one is your frontal recess? And again, as how Professor Kaziani showed you, when you put your probe, the frontal recess is always medial and behind your agonized cell. Okay. Now the only cell that is medial to your frontal recess or frontal sinus opening is the interfrontal sinus cell. So in this, you can see the supraorbital ethmoid cell, and that's your frontal recess. Okay. Now your interfrontal sinus cell, okay, this is on the right side, okay, and that's your frontal recess, and this is the intersinus septal cell, and it's the only cell that's medial to your frontal sinus, okay. So when you go up and you see lots of openings, okay, you always go to the most medial, and you go anterior to the supraorbital ethmoid, posterior to your agonized, and always check your CT scan. Okay, if you have an intersinus septal cell, that's not your frontal recess. It's an intersinus septal cell, and your frontal recess is lateral to it. So today, at the end of your dissection, this is what I actually want to see. Okay, you sphenoid sinus, sphenoid recess, posterior ethmoid artery, skull base, anterior ethmoid artery, frontal recess, and I think it's very nice that we could master this technique on the cadaver today. Thank you very much.
Thank you, Dr. Bilal. Now we'll go up to the lab. Kaziani will make a demonstration. After that, we'll start the session. Meanwhile, somebody wants to take a coffee there.
Okay, demonstration time. Demo. I could go now.
صديق ان شاء الله نستمر ونشوف ان شاء الله اصوات البارده ان شاء الله